Well, thanks very much to the organizers for giving me an opportunity to talk today. A real shout out to the Academy for drawing attention to this issue that I think has historically been underappreciated. I'm going to go through this presentation. I'm going to figure this out. Here we go. Just telling you a little bit about what harm reduction is, where it came from, give you a very high-level synopsis of the evidence on effectiveness, spend some time talking about Canadian harm reduction services and some new directions. And I want to start by just giving you a broad overview of where harm reduction came from and what it is. A good analogy that I find is helpful is this. Seatbelts, emission controls, speed limits, helmet laws are all pragmatic interventions to reduce mortality and morbidity associated with using vehicles and bikes without going through all the practical difficulties in stopping people from driving on the roads. So we can understand these interventions as harm reduction strategies to reduce the risks of motoring. Exactly parallel logic for harm reduction. Harm reduction, an approach to substance misuse that emphasizes pragmatic interventions to reduce mortality and morbidity associated with use of drugs without necessarily requiring people to stop using them. Harm reduction strategies have been developed for alcohol and tobacco, but I'm going to focus today on illicit drug use, as this is the greatest amount of literature and the most research. So no single definition or conceptual framework really captures the approach, but a number of key principles have been articulated, and these include pragmatism. This is the idea that we should accept that some level of psychoactive substance use is inevitable and normative in a society. We heard some references to that this morning. Humanistic values, where one does not condone or condemn drug use, regardless of mode of intake or level of use. The focus is on restoring dignity and rights of people who use drugs and avoiding moralistic judgments. Focus on harms, where the aim is to reduce harms irrespective of level of drug use. And importantly, harms are construed at the individual, community, and social or societal level. And lastly, a hierarchy of goals. The immediate focus is on addressing the most pressing health and social needs of people who use drugs. I will point out it's compatible with all sorts of other longer-term goals, such as accessing treatment and, indeed, with longer-term abstinence. Historical origins of harm reduction interventions. The philosophy can be traced back centuries, but the approach has been primarily developed in response to HIV/AIDS in the 1980s. Then it was recognized that abstinence-oriented treatment and criminalization would not be sufficient for stopping an HIV epidemic amongst injection drug users. This is because not all people who inject drugs are willing or able to attend treatment. Fear of police detection promoted a number of HIV risk behaviors, including sharing of syringes, rushed injections, injecting in unsanitary, unsafe conditions, and alienation of drug users from health services and their social support systems. Harm reduction intervention approaches were developed to address these gaps. Rotterdam, Netherlands, and Liverpool in England were early adopters. Harm reduction was seen, is closely seen with and aligned with the new public health, focus on social determinants of health rather than individual behavioral risk factors. Informal risk reduction efforts such as syringe distribution, bleach provision, importantly were grassroots, bottom-up initiatives by communities, and it was only later that health professionals adopted these and these interventions were integrated into health services. So peer-driven, yes. So as harm reduction spread and was associated with demonstrable reductions in HIV risk behaviors and HIV/AIDS incidents, It expanded to include interventions for other modes of drug taking and other related health risks. And you can see here the global penetration of syringe exchange as of 2012. So having given you a little bit of context, let me tell you a little bit about the state of the evidence on these interventions. There's an enormously large literature here that I'm going to really sail by very quickly. I can't do justice to, but I'm going to point out some key reviews and key studies that give you some important information. From a design point of view, except for pharmacological and opioid substitution therapies, it's very difficult to study these using randomized controlled trials, but a range of study designs have been applied beyond those cohort studies, interrupted time series, case control studies. And I will point out that the Canadians have made enormous contributions to this literature on effectiveness, and we should be collectively very proud of that. So, syringe distribution and collection. I point out that many syringe exchange programs have separated out distribution and collection and have ended one-for-one exchange practices, resulting in barriers to access for some people who use drugs. In needle exchange, programs have been subject to, I think, the most evaluation in the scientific literature. This was a review of reviews that concluded that these programs found strong evidence that sterile injecting equipment reduces injection risk behaviors, and more tentative evidence that provision of sterile injecting equipment reduces HIV incidence. This is a statistically rare event, more difficult to show. Other harm reduction interventions include take-home naloxone programs where we train people who use drugs and their loved ones to administer naloxone in the event of opiate overdose. This reduces mortality, especially in cities where police attend drug-related ambulance calls and may discourage, and those circumstances may discourage users from calling for emergency services. It's been widely implemented in the U.S. and only sporadically in Canada. And recent research from the U.S. Suggests that these distribution of naloxone can prevent overdose deaths. A recent survey of 48 of these programs published in the CDC Morbidity Mortality Weekly found that over 50,000 trained to provide these interventions, resulting in over 10,000 documented overdose reversals. Supervised injection facilities are sterile environments where people who use drugs can inject under medical supervision. Individuals are able to bring pre-obtained illicit drugs to these facilities without risk of arrest. SIFs are designed to reduce overdose risk and unsafe injection practices and connect people who use drugs to treatment and other health and social services. They've been implemented in 90 cities worldwide, but Vancouver is the only city in North America to have a legally sanctioned supervised injection facility. And this intervention has been heavily studied in Vancouver and in Sydney. Numerous cohort studies coming out of Vancouver and some elsewhere indicate that supervised injection facilities reduce risky injection practices, connect high-risk illicit drug users to health services, and promote uptake into addiction treatment and reduce overdose mortality. This particular report demonstrating a 30% increase in detox access associated with the opening of a safe injection facility and increased rates of long-term transfer to addiction treatment. Another example of benefit of safe injection facilities, this is a Marshall et al. Study published in Lancet. Using data from the provincial coroner service, the authors examined rates of fatal overdose in the city blocks surrounding Insight between 2001 and 2005, a period which bracketed the facility's opening in 2003, and found that for city blocks within 500 meters of the facility, that's where 70% of Insight's clients reside, the overdose rate decreased by 35% in the post-safe injection facility temporal period, and this is a significant difference. Safer inhalation kits, another intervention designed to help connect cocaine users to health and social services. to mitigate risks of using makeshift devices to help to smoke crack and other drugs, cuts and burns the lips and face being a mode of transmission for infectious disease. In general, smoking is a less risky route of administration than injection. And the evidence, preliminary evidence suggests that it may engage clients successfully and result in reduced pipe sharing, but these programs are still in pilot phases, and as such, there's no definitive evidence on this score. Street and peer outreach, where health workers and other peers contact illicit drug users in the community and provide them with information about risk behaviors, sterile injecting equipment, inhalation supplies, access to HIV/AIDS testing, condoms, and referrals to other health and social services. These programs have experienced success in reaching hard-to-reach populations and promoting positive behavior change. This review, published some years ago, published studies on outreach programs and concluded that the majority of 36 published evaluations show that injection drug users in a variety of places and time periods changed baseline drug-related and sex-related risk behaviors following participation in peer outreach. Other interventions, low-threshold opioid substitution. These supply methadone or buprenorphine to opioid users without requiring abstinence from illicit drugs. Heroin-assisted therapy, provision of pharmaceutical heroin to opioid users who have experienced difficulty in stabilizing on methadone or other opioid substitutes. And some evidence published recently on this score. This group report an open-label phase 3 randomized controlled trial conducted in Vancouver and Montreal, comparing injectable pharmaceutical heroin with oral methadone maintenance, and concluded that using an intention to treat analysis, rate of retention was greater in the pharmaceutical heroin group compared to the methadone group, and reduction of rates of illicit drug use or other illegal activity was greater in the pharmaceutical heroin group. So just to summarize, this is hardly a meta-analysis, but a way to try to point out that there's an extremely large international literature that would lead us to conclude that there's strong evidence for effectiveness of syringe exchange, supervised injection facilities, street and peer outreach, opioid substitution, equivocal evidence with respect to provision of safe inhalation kits, and promising with respect to take-home naloxone and heroin-assisted therapy. As a result of the strong international literature, the harm reduction services have been adopted. Harm reduction policies have been adopted by 93 countries worldwide. They've incorporated harm reduction interventions into their continua of supports and services for people who use illicit drugs. The approach has been endorsed by the WHO and UN-AIDS. Popular criticisms. Harm reduction promotes drug use and keeps people stuck in a pattern of addictive behavior. This is a time series analysis reporting out of Vancouver cohorts where they studied sort of rates of increased provision of syringe exchange from 96 to 2010. And over that period, the estimated proportion of participants reporting cessation increased from 96 at 2.4% to almost half of participants in these cohorts reporting cessation. In another study, these authors examined length of injecting career, and they studied over 1,000 users of the Safe Injection Facility in Vancouver and found only one individual reported performing a first injection at the Safe Injection Facility, and they concluded that the findings support the inference that the benefits of safe injection facilities are not offset by a rise in initiation into injection drug use. Another popular criticism, harm reduction promotes crime and community disorder. This is an older study from Baltimore that examined the impact of a needle exchange program on quantity of and geographic distribution of discarded needles on the streets of Baltimore. And this study. It's very interesting methodologically, but it concluded that there was no significant increase in the number of discarded needles over 32 city blocks in Baltimore, comparing prior to the opening of the needle exchange to past 2 months after its opening. Additional evidence from Vancouver on public injecting and publicly discarded syringes and IDU-related litter. In these analyses, the group reported the 12-week period after the opening was independently associated with reductions in number of drug users injecting in public, reductions in discarded syringes in public, and in injection-related litter. And the last one on this series, it looked at crime rates and concluded that if you do a pre-post comparison of crime in relation to the opening of the safe injection facility, no increase is seen in drug trafficking, assaults or robbery, and a decline in vehicle break-ins and vehicle thefts. Having said a little bit about the evidence for effectiveness, these range of interventions, what can we say about the state of harm reduction services in Canada? And I'll be blunt. I think it's best characterized as a poorly resourced patchwork of provincial and territorial services that are highly variable with respect to types of interventions used and the governance of the programs. What makes me say that in such a blunt way? Poorly resourced, DeBeck and colleagues analyzed Canadian federal funding allocated to Canada's anti-drug strategy, and these were Treasury Department figures. And the base federal drug strategy expenditures for 2004 and 5 are presented here. You can see enforcement activities taking 3/4 of the resources, treatment 14%, prevention 3%, and harm reduction 3%. They adjusted for new allocations provided in 07 and 08 and still concluded that enforcement, even with additional influx of federal anti-drug money, enforcement would still receive 28 times more resources and funding than harm reduction services. A patchwork of services. Well, in my own province in Alberta, only 6 communities have syringe exchange. In Ontario, we estimate only about 1/3 of public health units provides clean injection equipment. In large parts of Manitoba and Nunavut, syringe exchange not available at all. Variations in services. Until recently, naloxone distribution programs only existed in Edmonton, the first in the country. I'll put a plug in for Edmonton. Toronto and Ottawa, BC pilot underway. Canada only has 2 supervised injection facilities, both located in Vancouver. A recent provincial territorial review of methadone policies concluded that low-threshold opioid substitution programs are not provided consistently across Canada. Governance, I would claim that little progress has been made in integrating harm reduction services within treatment programs or other services and supports. Except for BC, in most provinces across the country, policy direction and funding for harm reduction services mainly flows from agencies or programs designed to address bloodborne pathogens. They are not usually located in addiction and mental health programs and services. And finish off, because I have just 1 minute left, on some directions on research. I would say that most health services research on harm reduction has adopted what I would call an instrumental rational model of health policy making, closely aligned with evidence-based medicine, health economics. This is a narrow construal of the types of evidence that would qualify for constructing policies to optimize health services for illicit drug users. Consider efficacy, effectiveness, cost, iatrogenic effects, and so on. The evidence to date is impressive, although certainly not complete, and it would support the effectiveness of implementing harm reduction strategies and interventions as a matter of policy. And for most health topics, this would support relatively unproblematic uptake into the system via routine KTE mechanisms. Yet the approach continues to be poorly supported, variable across jurisdictions, not systematically organized. Why would this be? I think it's that harm reduction services are a prototype of what we would call a morality policy in the health arena. That is to say, health policy making that involves clashes of core values about the legitimacy of providing certain kinds of health services for certain kinds of target populations. And as such, I think that policy-making shaping harm reduction services is more resistant than other services, such as hip replacements, to instrumental rational data and recommendations advanced in the extant intervention literature. So if harm reduction is an example of a morality policy, I would suggest to you that evidence on efficacy, effectiveness, costs, iatrogenic effects, and so on is necessary but insufficient to advance uptake of these interventions into routine care. And data are required to describe how policy stakeholders construe this value-laden, contested moral landscape about the rights of illicit drug users to access interventions. I don't think this is a matter of KTE and the usual sort of evidence pyramid. I do think it's a matter of coordinated efforts to modify attitudes and structural barriers that prevent these services from having greater uptake. So the last things I will say is that in conclusion, there's solid but not completely conclusive evidence of the effectiveness of many harm reduction interventions. Despite this international evidence base, Canada has a poorly resourced patchwork that's highly variable in the interventions used and its governance. And harm reduction services challenges traditional models of knowledge transfer and exchange, and as a prototypical morality policy making area, traditional KTE probably has some severe limits. Thank you.